Welcome, everyone. I am Mary Devereaux, the director of the Biomedical Ethics Seminar Series, and this is our fall meeting. In the time of COVID, we are meeting quarterly for now. We met in the summer, so this is our fall presentation, and I am absolutely delighted to welcome everyone on the call and also to introduce our guest speaker today, Rosamond Rhodes, who, as the title slide indicates, is at the Icahn School of Medicine at Mount Sinai, also at the Graduate Center CUNY. And she and I have not met in person, but I met or attended her talk at the American Society for Bioethics last month, and her talk is on her new book, which I will hold up, The Trusted Doctor, Medical Ethics and Professionalism. I hope people can see that. It's a wonderfully done book and quite substantive and provocative. So let me go ahead and finish introducing her. Dr. Rhodes has published over 200 articles and chapters on a broad array of issues in bioethics. Research ethics, genetics, transplantation, death and dying, conscientious objection, abortion and ethics education, and the distinctive ethics of medicine, which is our topic today. She's also co-editor of a number of books, including the Blackwell Guide to Medical Ethics and a second collection called Medicine and Social Justice, Essays on the Distribution of Healthcare. Her book that I just mentioned was published by Oxford just this year, so it's hot off the press, and we're very delighted to have her here to sort of present her argument in the book and to open up a discussion on medical ethics, professionalism, trust in the healthcare system, and so on. But before I turn things over to her, I should also add that Dr. Rhodes has received a number of awards, including the Special Recognition Award for Achievement in Medical Education, the Innovation in Resident Education Award, the Alexander Richman Award for Humanism and Medicine, and a number of others. So I would like us all to welcome Dr. Rhodes. I have already apologized to her personally for our inability to meet in person, but this is the way we do things in our current circumstances. So with that, I'm going to turn things over to Dr. Rhodes. And again, welcome everyone. We will have plenty of time for discussion at the end of the presentation.
Hello, I'm delighted to be with you and very happy to see Mary Devereaux in, at least visually. And I look forward to a discussion. I'm free to you interrupting me at any point if you have questions. So I'm a teacher, I'm used to that, and I welcome it. Okay, so I have nothing to disclose, and here's my agenda. So first, I'm going to explain what I take common morality to be. It's the standard approach to medical ethics. And then I'm going to provide two arguments. One I call the negative argument, and it's designed to show that common morality does not provide an account of medical ethics. And then a positive argument explaining why medical professions require a distinctive ethics and uncommon morality. Okay, so basically what I'm doing is hubris, full of pride, and it's very controversial because what we've been talking about in medical ethics for the past 40 plus years is the common morality approach. So I may have the common morality approach wrong. Both Tom Beecham and James Childress have told me I do, but I've tried hard to understand it. And if I can't understand it, maybe you don't understand it either. So here's my understanding of common morality. Okay, so common morality is the view that medical ethics is just everyday ethics applied to medicine. And it is the view that's been expressed by Beecham and Childress in all 7 editions of their Principles of Biomedical Ethics, and by Gert, Klauser, and Culver in their 2 editions of Bioethics. So there they are, Beecham and Childress, and they're very nice people. And their view is that what we do in medical ethics is draw upon common features of prominent moral theories, and they've identified 4 principles, the principles of respect for autonomy, beneficence, non-maleficence, and justice as, quote, the considered judgments that are the most well-established moral beliefs to serve as an anchor of moral reflection. And they also go on to say that particular moralities, such as professions, share the norms of common morality with all other justified particular moralities. So we have this history, Western history of ethics. They've identified 4 features that are really, really prominent and important. And for you to do medical ethics, all you have to do is slap those 4 principles onto the issues that you encounter in medical ethics. A slightly different version that Bernie Gert, Chuck Culver, and Dan Klauser would say are significantly different views are the ones presented by Gert, Klauser, and Culver in their 10 rules of medical ethics. So Beecham and Childress talk in terms of principles, Gert, Klauser, and Culver talk in terms of moral rules. And the first quote is from an encyclopedia article by Dan Klauser, where he's describing medical ethics, and he says, bioethics is not a new set of principles or maneuvers, but the same old ethics being applied to a particular realm of concerns. And in their book, the second version of their book, they write, many of the duties of the profession are particular applications of the general moral rules, which are valid for all persons in all times and places in the context of the special circumstances, practices, relationships, and purposes of the profession. So I understand them in that those broad claims to be taking pretty much the same position. So I ask the question, is medical ethics just the ethics of everyday life applied to medicine? And as I said, the common morality view is all bioethics is traditional ethics applied to novel circumstances. And in other words, it's making a universal claim. And the universal claim is all medical ethics is common morality, which would mean that doctors have the very same duties as everyone else, and the character of the doctor should be no different than anyone else's. Now, my view is the uncommon morality view that says, no, wait a minute, these are very different, and to refute a universal claim that all medical ethics is just common morality, all I need is a single counterexample, one black swan. But because 99% of bioethicists say common morality is medical ethics, or medical ethics is common morality, I'm going to offer you half a dozen. But remember, I only need one example to make my case that these are different. So counterexample 1. If a grocer runs out of oranges and telephones another grocer across town and requests a share of his supply, the telephoned grocer is free to deny the request. And if a neighbor asks you to look after his pet while he goes off on vacation, you may be blameless in denying the request. And if a neighbor asks for your grandmother's honey cake recipe, you may deny the request and keep it secret. Yet when a doctor receives a request from another to share medical resources, knowledge, or physical assistance in caring for a patient, the doctor is obliged to render the aid because physicians have a positive duty to respond to patient needs and actively promote their health, whether the patient is someone they are treating or another physician's patient. Counterexample number 2. In everyday life, we're free to make decisions any way we like. You can consult your horoscope, a funny feeling in your gut, or wish upon a star and see what happens, or flip a coin. Doctors, however, are expected to rely upon scientific evidence when they recommend a treatment for their patients, and gut feelings and the like are not acceptable for medical decisions. Number 3, in ordinary social interactions, we freely share what we know. We tell each other, don't order fish in that restaurant, you're likely to get sick. And don't lend that person $5, you won't see it ever again. And who's going out with whom and who just broke up with whom. We share information, it's entertaining, it's useful, we do it all the time. And in ordinary life, if you want something kept a secret, I can say, Mary, I have something I need to discuss with you, a problem with my daughter. Promise me that you will keep it secret. So in ordinary life, unless we make a promise, explicitly or implicitly, or sign a non-disclosure agreement, you're free to share what you see and what you hear and what you learn. But in medicine, confidentiality is presumed, although there also can be some exceptions. In common morality, we accept that we may associate with whomever we choose. There are some people I don't want to have coffee with or dinner with or lunch with, and I don't have to. But in medicine, professionals are supposed to be non-judgmental and minister to every patient's medical needs without judgments as to their character or worth. Today, you can imagine that many medical professionals have very strong feelings about people who don't wear masks and maintain social distancing. But if one of those people who've been, I don't know, shouting at rallies comes in with an illness or any kind of medical need, you're supposed to take care of them with caring and respect, regardless of how they were responsible for their own condition. Most people today consider sexual activities among consenting adults as ethically acceptable. In medicine, however, consent does not legitimize a physician's sexual involvement with a patient. We expect patients' invitations for tryst to be declined and that none would be issued by a patient, to a patient by a doctor. And in social situations, we think asking probing questions is rude. You don't go up to somebody you've just met at a cocktail party, remember those, and say, well, tell me about your bowel habits and your drug preferences and your sexual preferences. But a doctor is supposed to take a complete and detailed patient history and include asking about a patient's diet and bowel habits and sexual practices and drug use and fears and previous illnesses. Now, I put this together in a chart to make it vivid. So the idea that medical ethics is not everyday ethics. So there are my counterexamples and the duties of medical ethics. And you can see, look after your own interests. It's very nice to look after your neighbor's interests, but you don't have to. So looking after your neighbor's interest is an ideal. But in medicine, that's transformed to a duty. And for those of you familiar with Kant, we're talking about the difference between an imperfect and a perfect duty, and that's a pretty radical difference. Make choices your own way was the example, and doctors are committed to guiding their practice with scientific evidence. Again, an ideal is transformed to a duty in medicine. Things like confidentiality are even more starkly different. A permissible behavior becomes impermissible in medicine. Non-judgmental regard, judging the worth of someone. You can imagine Tony Soprano's doctors. They may not want to have coffee or lunch with him. They may not want to be in the same room with him, but if he has a heart attack or needs psychiatric care, the doctor has to handle their fear and take good care of Tony Soprano regardless. So permissible behavior in common morality becomes impermissible again in medicine. Non-sexual regard, again, a permissible behavior for common morality is impermissible. And this issue of asking probing questions is, again, impermissible behavior in everyday ethics becomes a duty for the clinician. So we all know enough about logic to know that from the same premises, you cannot get inconsistent conclusions. And if you're getting different conclusions for medicine and common morality, you must be starting with different premises. So that in itself is the sum of my negative argument that you can't have the same conclusions. You can have the same conclusions from the same premises if you're doing the same thing, but if you get inconsistent premises, I'm saying it wrong, inconsistent conclusions from what look like the same premises, they must be different. So the negative argument is everyday ethics cannot be the same as medical ethics. Now, before I move on to the positive argument, I have to make a further distinction. And here I want to distinguish between roles and professions. So roles are special places in society that we can take on, like being a butcher, a baker, or a candlestick maker. Now, I have these son-in-laws in Montana who do hunting, and then they butcher their own meat. Now, someone can choose this as their work and do it publicly, and they may require a license to do it publicly, but what my son-in-laws in Montana do and what the butcher does in the butcher shop is not very different and requires no special rules. And there are people who earn their living as bakers. They take on that role, and if they promise to make you pies for Thanksgiving, then they'll have a special obligation to meet that order. But ordinary people can do what a baker does. I make pies for my family when I get to see them, and I can bake chocolate chip cookies with my grandparents. We don't require any special rules for doing these things. And my grandchildren, when they go to school, do things like make me candlesticks. So no special responsibilities or rules are involved. Now, another point about roles is when you take on a special role, you have special responsibilities. And there are some duties that we all have, duties that we have to one another regardless of our place in society, like duties not to harm one another, duties not to deceive one another, are rules that everybody has all the time. But then there are duties that people have because they take them on. So some people choose to become pet owners. They take in a dog or a cat or a bird, and then you have to feed the animal. And if you are a dog owner, you have to walk the dog, even when it's rainy and cold and you prefer to sleep in. You have to take the dog out for a walk. So you get that duty because you take on the role. Similarly, parents, they might not like, I don't know, dealing with smelly, messy things. the child vomits, you have to take care of it. You have to change the diapers. You have responsibilities because you choose to take on that role. But nothing that the parent does involves special rules or special legal permissions. But think about medicine. And here's the substance of my positive argument. When you think about medical professionals, they certainly have a whole array of special knowledge, but anybody who buys books and reads them can develop this special knowledge, and microbiologists needn't have the duties that a medical professional has. What makes a profession very special is their powers, privileges, and immunities. And here I'm drawing on a legal tradition to explain these concepts. So the powers that medical professionals have, and doctors in particular, are the power to determine that a patient lacks decisional capacity and impose treatment over objection and restraining free movement. They also have the power to allocate scarce resources, transplant organs, places in the ICU, vaccine, and the power to collect samples from patients and data about patients. These are extraordinary powers that no one else has. And they have privileges like probing people with questions, examining nakedness and insides. And the language we use when medical professionals examine nakedness and insides are actually starkly different from the language we use to describe ordinary people. So in ordinary morality, it would be, you see somebody attractive walking down the street, you look at them in a special way, and that's ogling. In medicine, it's inspecting. You caress someone's body, it's caressing or fondling. In medicine, it's palpation or examination. So it's even different language that we use. Administering poisons. Now, many of the medicines doctors give, they will caution patients, or the pharmacist will caution patients, be careful how much you take. This can harm you, this can kill you. If I give somebody a concoction and say this can harm you or kill you, I can go straight to jail for administering poison. And we impose risks and burdens on patients all the time and inflict pain. A doctor who's examining rebound tenderness causes pain. And then medical professionals get extraordinary immunities. So if I cut into someone and remove a pound of flesh, I go straight to jail. But the doctor does it, we say, thank you, doctor. So medical professionals doing these things are employing their powers and privileges. They don't go to jail. And if things don't go well, unless there's malpractice, there are no untoward outcomes. So the point is that medical ethics is an autonomous field because the duties of medical professionals are not derived from the precepts of common morality or any other field, and they cannot be deduced from common morality or any other field, and they entail the distinctive powers, privileges, and immunities. And this is the key point. If you're not allowed to do things like remove a pound of flesh in common morality, if you're not allowed to do it, then there are no rules in common morality governing how you are to do it. If no one outside of the profession is allowed to distribute poisons to people, then there are no rules in common morality to tell you how to distribute poisons to patients. it has to come from somewhere else, and the somewhere else is medical ethics. So just to summarize this position, medicine's knowledge, powers, privileges, and immunities are granted to the profession and professionals only on the condition that medicine can be trusted to wield them for the good of patients and society. And these distinctive rights that medical professionals get, and the warrant to perform actions that are impermissible for others, and the monopoly over the field, we all notice that they're extraordinarily dangerous. So because doing things like removing a pound of flesh and distributing poisons are dangerous, interacting with people's naked bodies, again, dangerous, we need to have rules that govern them from medical ethics. So the first and fundamental duty of medical ethics I see is seek trust and be deserving of that trust. And the second duty is that the duties, the powers, the privileges that are granted to the profession, that they be used only for the good of patients and society. So the second duty of medical ethics is use medical knowledge, skills, powers, and privileges and immunities in serving the interests of patients and society. Now, I think that every profession, what makes it a profession is it's having distinctive powers, privileges, and immunities, and therefore the first principles of each profession will be very much the same as the first two principles of medical ethics. And they will be seek trust and be deserving of it, and use the distinctive powers, privileges, and immunities in serving the interests of patients and society. Now, this kind of approach to medical ethics has very significant implications for medical education. First of all, it means that moral guidance from common morality is an inappropriate starting point for medical ethics education. So one thing I know that I used to do years ago is give first-year students some cases and ask them, what do you think? When I would ask them, what do you think should the doctor do, should the nurse do in this circumstance? What I would be doing is asking them to use what they know from common morality and apply it to medicine. And if I'm saying that is inappropriate, then you can't start by doing that, because we don't want them to import the ideas of common morality into their treatment of patients in medicine. Another implication is that the special duties of medical ethics have to be defined and explained and inculcated. And that means you have to spell out what they are. It took me 32 years to figure out 16 duties. I'm sure there are more, but it's not easy to sort out what they are in detail. And then they have to be explained. What is the content of this duty? What's the rationale of it? Why is it absolutely essential, for example, that doctors tell the truth? It may not be obvious. And then medical students have to learn how to apply the concept in an array of clinical circumstances where that concept may be relevant. And then the commitment to those duties has to be inculcated. If you think about ordinary people, they see somebody vomiting or in pain or bleeding. The reaction most of us have is standing back, and doctors have to learn to jump in. So it's a very different reaction, and it has to be learned. You interact with patients, you go to a hospital room, you go into one room in the hospital, and your patient has been cured and is going home well, and you share in the joy with the patient and the family, and you're there in the moment. And you go to the very next room where you have to deliver terrible news, and you have to switch on a dime from one behavior to another. And in ordinary life, people would think you're being insincere. And in medicine, this is a learned skill, how to lay on your hands and comfort a patient and communicate these very difficult things that most people are afraid to say. And then another really critical concept that I think belongs in medical education is that you are training for the profession. So I used to teach undergraduates at Hunter College and at Loyola of Chicago, and the goals in teaching undergraduates or even graduate students in a philosophy program are very different from training for the profession. In an undergraduate class in philosophy, you want students to share their ideas, and we let all the ideas people have, we think they're great and we want to explore them and they're appropriate for discussion. But when you're training people to be exemplary doctors, there are some things that are just unacceptable. For example, being judgmental about your patient, coming to the conclusion that those people who didn't wear masks don't deserve treatment, or can be made to wait long, or can be suffering, allowed to suffer. It's just inappropriate for medicine, while it might be very appropriate in everyday life to have judgmental attitudes. Parents teach their children, be careful with whom you associate, and in medicine, you can't do that. You have to take care of the patients who need your help, whether it's the drunk driver who just caused great injury to a family, or the injured parties. You have to treat them all with caring and respect. So in training for the profession, you're not training undergraduates, and you're trying to create exemplary doctors who have to understand their duties, who have to develop the knowledge and skills, including the skills in ethics and communication, to become a good doctor. And you have to inculcate the inclinations to behave in a doctorly way. Going back to Aristotle, we call this virtues, a little bit of a dated word for now, but we talk about attitudes and inclinations. And there are ways of behavior that it's legitimate to expect of doctors, and ways of behavior that are unacceptable. And we want our doctors, or who we've trained, to be and do the kinds of things that the exemplary doctor should do. The one thing I didn't go into was this idea of this distinctive ethics, like where does it come from? I think it comes from people just thinking about the kinds of duties you have and formulating what the duties must be. And if you look, starting it with the Hippocratic Oath, you see some of them laid out clearly there. And I've looked at the codes of medical ethics in countries in the English-speaking world, and it's quite remarkable how consistent they are. They're not perfectly consistent. Some are longer than others, but for the most part, the commitments that they identify are very much the same and largely consistent with what I've laid out here in this list. I can't believe there's nobody who wants to argue about whether medical ethics is different from common morality.
How do you want us to ask questions? Just jump in?
Jump in, sure.
My name's Daniel Kasoy. What I'm wondering is, are you saying that the ethics that you are proposing is mutually exclusive from the common morality framework?
Yes. So I think someone named Len Fleck, a philosophy professor in Michigan, has commented on one of my papers arguing this basic presentation. And he explains it as medical ethics being a different species of ethics. So there's ethics all grounded in fulfill your commitments, keep your promises. But just like there are all the animals in the world, giraffes can't mate with rhinos. It just doesn't work. It doesn't happen. There will even be different species of giraffes that cannot mate with each other. So there are different ethics. I think the ethics of the medical profession is going to be very different from the ethics of the judiciary, and very different from the ethics of the military, and even the ethics of rulers. So we have different ethics, and they will be similar in some respects, but different. So when we have things like respect autonomy, we have a duty like that. I have it listed in this list as duty number 10. It's really important in Beecham and Childress, not important in Gert, Klauser, Culver, but we have it in common. For me, the justification for why autonomy should be respected is because patients will not trust you unless you take seriously what's important to them, their values. Think of the Jehovah's Witness. If they didn't trust that you would honor their refusal for blood transfusions, they wouldn't let you provide all the other help that you can provide. I don't know if that helps. Daniel, does it become any clearer?
Yes, I got cut off because my phone died, but I guess you got the question about mutually exclusive, so I caught the end of it. I guess my question is, I understand your point about seeking trust and be deserving of it seems critical and essential, but is that the domain of ethics, or is that just an additional feature or requirement or benefit, that you should do that if you're going to be a physician? So I'm like, is your framework kind of a mixture of ethics plus others that are drilling down more specifically on what is very important for a doctor to do, and the way in which they must behave? So anyway, just
okay,
figure out how they overlap or don't overlap, or whether you're citing very important additional things that aren't necessarily ethical.
I think making a commitment and fulfilling it is the basis of ethics. That ethics didn't grow up in the Garden of Eden or some particular jungle. It is a human creation. So that's step one in my thinking. That's consistent with a whole line of philosophy, starting at least from Hobbes, maybe going back to Aristotle. It's something we create that didn't exist but for our creating it. So where does it come from? So I can imagine some primitive group. They recognized that people sometimes get ill and people sometimes get injured. And wouldn't it be really, really neat if we had some expertise who could help address illness and injury? And they turned to some smart people in their community and said, we'll let you do things that nobody else will do, as long as you use those powers and privileges that we allow you for the good of us. So what they recognized from the get-go is, unless we can be trusted, this group of, we'll call them now medical professionals, whatever they got called in the primitive group, unless the rest of the community trusts our use of these powers and privileges, we're not going to be able to do our work. So it all starts from the trust. Now, what is necessary to keep that trust? Certainly using our powers and privileges for the good of the people in our society. And then you think, what else is important? Certainly something like professional competence. If you're giving people some potion to drink, if it kills them, you're going to lose their trust. So you have to really figure out what you're doing and develop expertise in it. Provide care based on need. If people really, really believed that you're only going to use these powers and privileges for the people you like, they're not going to be able to trust you. You might not like me. So they're all the rest of the duties, I think, are derived from the basic duty of seeking trust and deserving it in the use of the powers, privileges, and immunities that society allows. So the ethics of the profession, I'm saying, is distinct, different, a separate species of ethics. And even though there are many things that doctors do that look like common morality, the rationale will be different. Being truthful in your reports. You can spin out a very Kantian explanation of why you should be truthful. It's going to be different, though, in medicine. You should be truthful unless your patients believe that you're telling them the truth. They're not going to take the medicine 3 times a day, especially if it tastes nasty. Women aren't going to go and get their mammography because it hurts and it's inconvenient, unless they really, really believe you. So to maintain that trust in what you say, you must be truthful. So it's a deduction, very much like geometry, but from understanding what the powers and privileges you have are and what's necessary to use them. So I'm thinking, yes, I think it's different.
So this is Lynette from UCSD. I'm just thinking about this in the framework of professional ethics in general. So, you know, we have our set of professional and medical ethics, but each profession has their own set of professional ethics standards. And a lot of these, I would say, overlap with other professions that have special powers in society. So we have certain special powers, so to speak, where physicians are the only people in a society that are allowed to, like you said, go in and take out a pound of flesh out of somebody. But we have policemen that people have to trust that have power over us. We have the whole legal system, the lawyers, the judges, prison guards. We have the whole educational system that we entrust ourselves to be honest and behave within the parameters of their own professional ethics. And I think all professions derive their ethics from some kind of a basic foundation that we share. We just have different kind of powers or special areas of applying those ethics.
That's exactly what I'm saying. So I think the ethics of each profession is going to be somewhat different, and in some cases there will be overlap. So in medicine, we have the duty of non-judgmental regard. For the judge, you also have the duty of non-judgmental regard. The judge has to maintain, you think it's a terrorist bomber, but you have to maintain the attitude of being non-judgmental, which is very different from, let's say, the military. They're going to have very different responsibilities. So again, in the military, they're the people who can drop bombs and deliberately kill people. And we wouldn't allow them to do it, but for our trusting them to constrain those powers and privileges within a set of duties. So you see in a profession, a sociologist will tell you that you'll see in all these different professions that people swear an oath. And the swearing of the oath is very much the public declaration that I can be trusted in the use of my distinctive powers, privileges, and immunities. And I think for all professions, you're going to have the same first two commitments to uphold the trust and be trustworthy. And the second, that these distinctive powers and privileges will be used for the good of society. We have, I think it's also very applicable to our political leaders. And one of the problems we have, I think, is that we're not recognizing that these are professional responsibilities. They are the people who can take away your money, taxing. We don't call it stealing, we call it taxing. They're people who can limit your liberty. We call it laws. So they also have extraordinary powers and privileges that no one else has, and it's important to recognize that they're a profession and they have duties of trust and duties of using their powers and privileges for the good of all of us. So I think it's a very broad view. I've only worked on the ethics of medicine, but I think you're absolutely right.
So, Rosalind, I just wanted to see if you have more slides you wanted to present, because I see that there are a couple of other questions in the chat, but I didn't want to get us too involved in the discussion if you had more
so this
that you first wanted to present before we...
No, that's fine.
Oh, it's fine. Okay. So there's actually a question, just kind of monitoring the chat here from Chris Matthews. Hi, Chris. He asks, does the uncommon morality sort of framework, or the theory of uncommon morality as the basis of at least medical professional ethics, provide a more satisfactory framework for adjudicating certain controversial cases? And then he lists euthanasia, or maybe what we tend to call physician-assisted dying would be in there as well, abortion, germ cell alteration, and so on. So I'm wondering if you might answer that, and if the answer is yes, maybe illustrate how maybe this framework, rather than using the ordinary morality, might advance some of these sort of very important social discussions that have a medical sort of scientific component.
So one of the important things to recognize is that when you put on the white coat, become a medical professional, and I'm using that term broadly, when you put on the white coat, you're basically making a commitment to guide your professional action by the ethics of the profession. And what we see with abortion, euthanasia, or physician aid of dying, all of those kinds of issues, what complicates it is people start referring to religious values or other values outside of the professional code. And it's that mixing that people aren't recognizing clearly, that in making these professional decisions about action, you should be referring to the professional code and not your separate morality. There's a big argument in bioethics about conscientious objection, and Dan Sulmazy has argued about conscientious objection looking at John Locke's letter on tolerance. And so Densel Maisie very much wants tolerance for doctors who have different views. And if you look carefully at Locke's letter, Locke is making the kind of distinction that I am making. So what he's talking to judges, and he's telling judges, you might have very strong personal feelings about, and this is all about Catholics and Protestants, about those other guys, whoever are the other guys from your point of view. But when you're the judge, you must be non-judgmental. So it's recognizing that while we have to be tolerant of the views that other people have, they could be, our patients could be anti-abortion or pro-abortion. We can have strong personal feelings about their views and the kind of behavior that it allows. But as a medical professional, your job is to be non-judgmental. And if you can't put those personal views aside, this is very hard line. It comes down to saying you shouldn't be in this profession.
And if I can just interject, Rosamond's book that I was showing you at the beginning actually has a chapter near the end called Professional Responsibility and Conscientious Objection. And I think maybe this is one example where Chris Matthews' question gives you an opportunity to sort of show how this framework pays out in a particular sort of instance.
Right. Another place where it pays out in instances are places where we have disagreements between common morality and medical ethics. Things like non-judgmental regard, or where's another one? Police the profession, I think, is an interesting one. The duty to be your brother's keeper. In ordinary life, it's very fine to say, you know, it's his business, let him do what he wants. You know, if he's cheating on his taxes, it's not my problem. But a doctor who is failing in medical responsibilities, that's all of our responsibility. And most medical institutions have ways of reporting and policing, and there are tests and standards that you have to fulfill that are really, really important to have there. And you have ongoing discussions in medicine about whether there should be a duty to blow the whistle or how to make it easy. So it's where you have differences between the common morality and the professional morality, where it really matters, because if you're accepting that this is a distinct and different matter, something that should be governed by the profession, then you understand where your duty lies. I have to follow my professional duty, not what I might be free to do with common morality.
Okay, other questions? Or a couple in the chat, but maybe I'll open up some space for others who want to ask their questions verbally.
Can I ask a question?
Sure.
Yeah, I'm Sean from UCSD, philosophy grad student. So I really like the point where you're saying some ideals or imperfect duties in everyday philosophy, in common morality becomes perfect duty in bioethics. So I wonder, are these 16 duties all perfect duties? And if so, do you think, like, what do you think there are some examples of imperfect duties in bioethics? And what are some ideals that doctors should have that are not, strictly speaking, perfect duties?
That's a new question for me. I think these are all strict duties. What you do have, however, is the possibility, as soon as you have more than one, you have the possibility of conflict of duties. And by having one as the top duty from which the others are derived, you have a way of resolving conflicts. So the fundamental duty is seek trust and be deserving of it. And when you have a conflict between these other duties, trying to sort out what should I do in this situation, then you think about if it's going to end up in the New York Times, what is not going to undermine the trust of the profession? If it becomes commonly known, what is not likely to undermine the trust in the profession? And we can think about the ways trust in medicine can be quickly eroded. I recall, many of you probably also recall, how Mickey Mantle got a liver transplant, and then Steve Jobs got a liver transplant, and people thought the system had been gamed. Actually, the system had not been gamed in their allocation of the organs, but people thought they got special treatment. And organ donation declined very dramatically. And it just shows how fragile this trust is in the medical profession. There was an article recently, I probably have it on my desk, about someone explaining vaccine reluctance, vaccine hesitancy. And this was an anthropologist in England who was working on this problem, and she found that people who were reluctant to accept vaccination, they're not stupid and they're not crazy. They've just had their trust in vaccines undermined. We see that in the election. Again, the trust is undermined, and you can't go forward, you can't robustly provide the help and support for people that you want to provide for them unless they trust you. So the trust is essential, and this is back to Daniel's question. Everything flows from that.
And there's a question from Arnold Gass, who's one of our local physicians, also about trust. So maybe this is a good segue. I'll just read it, and then Arnie, go ahead and jump in if you'd like to elaborate. He asks, or he comments, in the special case of medicine, trust is an a priori requirement. Recent surveys show that an increasing number of persons have reduced or even lost trust in the medical profession, although they may trust their personal physician. And so his questions to you are, why do you think this is happening? And how can one apply the other 15 duties if trust is either not in existence or fragile?
Well, I think trust is fragile, and you, as a doctor, a clinician, you're going to have a hard time when trust is not robust. So we have all the stories of African Americans feeling distrust of doctors, particularly doctors who don't look like them. And it takes work, may take extra time in the initial visits to establish trust. And if it's not there, it's just going to be harder. So how is it eroded? Stories people tell one another about doctors violating confidentiality, or doctors performing a procedure for money that wasn't really necessary, of doctors harming them. So the stories that people tell each other, you see it in the media, now you see it in tweets and Twitters and in movies. Those stories undermine trust, and the only way of getting it back is by behaving in a trustworthy manner and remembering how fragile it is, so being extraordinarily careful to uphold the duties of the profession.
It's interesting. Trust has become a philosophical topic, I think, lately. And one of the things that strikes me is that trust is really, I mean, trust is binary, right? You've got to have a truster, trustee, I guess. But it's also really asymmetrical. It can take a long time, particularly in certain circumstances, to establish trust. But the loss of trust can happen really quickly, and it's very, very difficult to recover from a loss of trust. I don't know what more to say about that, except that I find it very interesting, particularly given that, Rosalind, your schema rests so, I mean, trust, the seeking of trust and deserving of it is in the first position, so it's at the top of our screen, but really, if you think about it conceptually, it's kind of the foundation of the theory of professional ethics that you're giving us.
That's what it's meant to be. It's the foundation, fundamental principle, and it's absolutely necessary when you think about the extraordinary powers given to the profession. Nobody would allow you to do the things that you do unless they trusted you. So it has to be the foundation, fundamental. And one thing I want you to notice about my list of 16, 1 and 2 are in a rigid place, and nothing else is in a rigid place. It isn't that number 16 is less important than number 7. They're all important. 1 and 2 are the most important.
Stan Terman here. Can I ask a question?
Please.
Sure, Stan, go ahead.
What if there's a conflict between, for example, number 4, provide care based on need, and number 10, respect the autonomy of patients? And what I have in mind is the classic conflict between the planning principle who created a living will, which says, if I'm in a certain situation, condition, and advanced dementia, do not put food invading my bodily integrity into my mouth. But the duty of the physician, he believes, is to care for the patient in front of him.
I think that caring for the patient in front of you, I think this gets back to the respect for patient autonomy, that patients wouldn't allow you to treat them. So I can imagine a patient with a very serious condition, and they say, look, I don't want to end up in a nursing home being kept alive with artificial feeding for years and years. You have to promise me that you're not going to do that to me. And I've written down on my advance directive, no one is to feed me unless, whatever the conditions are, unless I can be restored to cognitive function. Okay? And you promise them, okay, I will abide by your advance directive. And now they let you treat them and treat them. They wouldn't let you treat them but for that promise. And now if you think about the trust in the profession being fragile, if I'm the patient to whom you promised it, and now you put artificial feeding, you give me a peg tube, and my dear friend Barbara comes in and says, you promised Rosamond that you wouldn't do that. And now Barbara's going to tell all the people she knows. What happens to the trust in the profession? So it isn't that, it's that in this circumstance, the trust is fragile because people talk to each other, they see what's happening, and it's going to be known that you can't trust Dr. Stanley because he breaks his promise when he thinks he knows better for you. Now, an important part of respect for autonomy is that you allow people to prioritize their own values. It's more important to me to avoid this continued living in the nursing home than it is to live an extra 6 months. And you have to take my priorities very, very seriously. So if you recognize that there are a lot of things people value, there are some things that are idiosyncratic values, person's own religious beliefs, their own aesthetic values could be very idiosyncratic. Other things everybody values, like wanting to avoid death, pain, disability, loss of pleasure. But we prioritize these things differently and in different circumstances. And an important feature of respect for autonomy is we say to patients, I'll do it your way. Of course,
But
there are
two
limits.
ways. Suppose the advanced dementia patient is pointing and grunting to the food put in front of him and then to his mouth. And the physician says, well, we have two Stan Termans now. We have the Stan Terman who wrote the living will, and we have the Stan Terman who's grunting and saying, feed me, feed me. 4 and 10 are then in conflict. How do you resolve that conflict, Rosa?
Well, I'm going to move us on just because there are a number of questions in the chat. And I mean, one question I think that might move us on, Stan, is the idea that providing care doesn't require that someone have a feeding tube. But I think the case you're talking about is a very complex one, and I think it's probably going to move us away from today's topic, which is really this framework of professional sort of ethics. So let me pull one comment. This is from Leslie in the chat. This is a comment rather than a question. But since we're talking about trust, she points out that one perhaps contributing factor here to the general erosion of trust in the medical profession, particularly maybe in physicians, is the lack of clarity about how much medical services will end up costing, that is financially. And that this really isn't up to the individual physician, but nonetheless, the financial sort of piece here may actually play a role in eroding trust, because of course one of the other things that ends up in the newspapers or on social media is, I went in for a COVID test and it cost $6,452. So I don't know if you'd like to comment.
Well, I think transparency supports trust, and people should know what things are going to cost them. And the dentist can tell you how much something's going to cost you. I don't see why the physician can't. Hospitalized patients, it gets a lot more complicated. But part of the problem is the system we have, where you can't be, where nobody knows is the answer. And so there are systemic problems in the way we run medicine today that undermine trust, and that should be part of what we need to fix in medicine.
Anna asks in the chat also, if I can sort of rephrase, I think I've got this right. The question is, how do we reestablish trust once trust has been lost? And of course, right now we're really talking at the level of the individual physician and patient. We could bump this up several levels and talk about some more general kinds of questions. But I'm wondering if you have thoughts about in the one-on-one situation, how one goes about reestablishing trust.
In the one-on-one situation, it may be the easiest part to confront, but it requires communication in words and showing that you care. We have the dramatic example of when a medical error occurs, and that those kinds of circumstances are the ones most likely to undermine trust. This bad thing happens. The orthopedic surgeon had to do a surgery. They know that a foot drop could result, and the orthopedic surgeon explained it in the informed consent that this complication could occur, and then it happens. And what do you do? Now, this isn't just me speaking. Medical malpractice lawyers do these seminars where they give doctors advice, and their advice is go to the patient, explain clearly what happened, show that you care, show that you're there for the patient, take responsibility, say things like, and I will come in and check on you 3 times a day, 2 times a day, and we will work together to try to develop the best outcome possible in the circumstance. So I think showing caring, showing respect, showing sympathy, taking responsibility are very important. It's an ongoing process. Being patient with people, family members and patients who might yell, who might cry, and learning how to manage those conversations. I think is part of what gets you there.
So part of medical education too.
Yes.
We've got another question from Christopher Matthews again. And this maybe is going to change our level from one-on-one to a much larger question. And that is your framework, if you go up to principle 2, which is again, one of the foundations, that all of these skills and powers and privileges should be used in the service of the interests of patients and society. And so this kind of very foundational question is, what criteria does this framework offer to determine what are the interests of patients and society? Particularly, I will just interject, given the plurality of values, attitudes, not only towards medicine, but towards so many other things, health, autonomy, what right I have to do things to my own body that may in fact bear upon other people's, well-being and so on. So, so how do you identify or think about this notion of serving the interests of patients and society? We have to have some sense of what those interests are.
Well, I think our being human beings gives us a lot of sense of what's in the interest of people, and then you can ask the patient and they can tell you. But built into this question is a kind of challenge to the usual understanding of medical ethics. So in usual understanding of medical ethics, we have statements like act in the best interest of the patient. Now, that's fine if you have one patient. You're the doctor to the king. As soon as you have more than one patient, you have the possibility of conflict of interest. And I specifically put in patients and society because there are these conflicts. So medicine is a complex role. Being a physician, you have a profession, but it's a role, like the parent role. So if you are the parent to Johnny and Sally and Susie and Martha, they may have different preferences about how to spend a vacation or what to have for dinner. And what's good for Sally may not be good for Martha. And you have responsibilities like putting bread on the table, and you're the educator and you're the disciplinarian, and they're complicated and they can conflict. So part of being a good medical professional has to be sorting through these conflicting obligations and figuring out in each circumstance what has to be done. And doctors do this all the time. When you have limited time and you have several patients, they're the ones in the waiting room and the one in front of you, how much time do you spend with each? And you're going to make decisions. Sometimes you try to give these patients equal time, but sometimes a patient who's just had a difficult diagnosis might require more time. Or a patient in the middle of an emergency will require more time, and you're making those decisions constantly. So it requires a lot of discernment and judgment and figuring things out. Now, for the most part, taking the bigger picture, I think medicine has done a wonderful job. Like we talk about justice and justice in medical care. And I think medicine, I don't think they don't use the language of the philosopher very often, but they've done a superb job of figuring out what kind of principle will be appropriate for different circumstances. So in the ordinary office visits of people, for the most part, getting their annual checkup, you try to do equality. Everybody gets a half hour or whatever is allotted.
5 minutes.
5 minutes. But in the emergency room, we use a different principle. The person who's in the middle of a heart attack or a stroke, they get seen first. So urgency rules, which is very different from the ICU or the transplant person. So who gets admitted to the ICU, we use a different principle of triage. We don't admit the people who are not likely to derive a significant benefit. People who have metastatic disease aren't going to get the liver transplant. So we use different principles, and doctors have been really, really good at figuring out, for the most part, which principle goes to which kind of allocation. And when you get extra complications when we start introducing concepts from common morality. So one of the issues that's come up with COVID is the allocations of hospital care or vaccine. And people have talked about, well, a lot of people of color, more than their proportion in the population, have come down with COVID. So should they get extra consideration and treatment? And the answer is not because of the color of their skin, not because they haven't had fair quality of opportunity, or not because they're not least advantaged. The reason they get extra treatment is if they're in a high-risk group. I don't want to say a high-risk group, because that's ambiguous. They're a group that has a great deal of exposure to the disease, so they're more likely to become victims of the disease and in turn vectors of the disease. So it's because of their exposure risk that they should get priority, not because they're from a group. So doctors have been really good at thinking through a lot of these issues, and they make these hard choices between patients and society.
Other thoughts and questions?
Okay.
Where does paternalism fit into your beautiful scheme of 16 duties?
I think this is the place of, where would I put that? It comes up a lot when you're judging whether a patient actually has decisional capacity. So it comes up all the time. There is number 11, assess decisional capacity. So if a patient is refusing a procedure, a surgical procedure, and we had a case like this just come to the ethics committee. It was a pregnant woman who was refusing a C-section. And it turned out she needed the C-section because there was fetal distress, and there was also a determination that the fetus was extremely impaired. And the question came up, should we impose a C-section upon her or abide by her refusal of the C-section? Now, what was her reason for the refusal? Well, she was afraid of needles and surgery. Now, if you're afraid of needles and surgery, I'm afraid of heights. So if I were on a, I don't know, one story up and there was a fire behind me and Mary said, Rosamond, jump, there's York's bravest, they'll catch you in this little contraption they have and you'll be fine. I'd say, I'm still not going. Why? Because I'm afraid of heights. You'll never get me to jump off the ledge. Somebody should push me. So if that's the issue, then you push her. In our patient's case, we had this extremely impaired fetus that she had gone to genetic counseling, but then when genetic counseling wanted her to have a genetic test, she had refused it because it required a blood draw.
Oh, wow. She really does have a fear of needles.
She had a fear of needles, and this fear of needles was a complicated case. The fear of needles was tied to an injury she had. She's deaf now from some medical mishap, an iatrogenic problem that occurred in her childhood. So she's has a fear, there is a source of the fear, and now should we impose the treatment on her, the C-section over her objection? The child, the fetus, had a condition that was likely incompatible with life. We didn't have the genetic diagnosis because she refused the genetic testing, but from what they could see, and there was no other way of delivering the baby. And we determined that she wasn't at any particular risk now from continuing the pregnancy. And there were other details about what she said and what she was worried about that led us to the conclusion that we shouldn't impose the treatment on her. So we make a decision. You're going to be making decisions about when it's justified and when it's not. And it all turns on, does this person have decisional capacity? And that's a medical responsibility to assess the capacity. So we determined she had the capacity. We weren't going to impose it on her. She was not at great risk, and the fetus was going to die anyway.
I think in most states, if the woman, if the laboring woman has capacity, my understanding was that you could not force a C-section, even if the fetus was in distress and had no other problems and could easily be saved. We had a case like that many years ago.
Well, here the issue was, did she have capacity? Now, interestingly and relevant to all of this, assessing capacity is a medical responsibility. Nobody else, the philosopher, I can say, I don't think she has capacity for this and this reason, but I don't have the authority to say
Right.
no capacity. And she had said inconsistent things. She wanted to hold her baby. She cared about the baby living, and then she was refusing the C-section. So it was a more complicated sorting out. She said things about her partner losing his job and worrying about caring for her other children, and putting it together to decide, does she have capacity or not? And you're absolutely right. If we decide she doesn't have capacity, then we could make the decision in her interest. But if we decide she does have capacity, we're going to abide by her choice.
Even in that situation, you still have to turn to a surrogate. You can't just make the decision unilaterally as physicians. You have to
If
find
there is a surrogate.
Right.
Right.
And we get a lot of those unbefriended,
Yeah.
where there is no surrogate. So a lot of the times it comes down to, we're making a decision and it all turns on, does this person have capacity? And I think you have like the Brock and Buchanan scale of how, like, when somebody's refusing a life-preserving treatment, we want a robust demonstration of capacity, while if they're refusing an extra blood draw, that really isn't important. And they say it's because there are Martians dancing on the roof, we'd accept their refusal. So it's becomes a complicated judgment.
Mary, I have one question.
Go ahead, Arnie.
Goes back to the beginning. So at the beginning, Dr. Rhodes, you talked about Beecham and Childress's principles, and I see the title of your book is called Medical Ethics and Professionalism, and I had the notion that maybe you were challenging them in some way, maybe because they didn't cover as much as your 16 points, but I actually went through all 16 points, allowing for the first two to be standalone. And the only things I could find, and I don't have them up in front of me, but numbers 12 and 14, the only ones that I couldn't fit under those 4 points, and they fit under the notion of truth telling. So I guess my question is, what is your bottom line statement about the 50-year-old project of Beecham and Childress?
So how does it misguide us or mislead us?
Whether, I mean, should we still, so there are different things. When I look at it, 16 duties of medical ethics, I have even trouble with the semantics of that title, frankly. I think those are the 16 duties incumbent upon the medical profession based on medical ethics, a unique set of principles, okay? That's how I look at that slide. Maybe I'm wrong. But my point is, can we still use Beecham and Childress's points as the major functional way to address ethical issues at the bedside?
I don't understand why you would want to. So I think the 4 principles as people understand them, they're extremely vague. And to get to be truthful in your report or be responsive to requests from peers, I think it would be really, really hard to get there from Beecham and Childress. So they want you to go through this very complicated process of specification and specification and specification. And doctors often have to make decisions in a very short amount of time. So going through the specifications is a problem. You want to know what is your job. And so that's a problem. Now they're very happy with people coming up with different solutions. I'm not so happy with that. So they're extremely tolerant of inconsistency. And I think we want the team on the same page, and they want to be on the same page. So one, the vagueness means that it's not very useful. 2, the procedure that they want you to go through is very difficult and allows people to come to different conclusions. And I think we want, not just we as medical professionals, and I'm including myself, the public wants to know, what can I legitimately expect from my doctors? What can I legitimately expect from my nurses? And the more that's specified, the more it encourages trust. So I'm being quite radical here in saying we've listened to this 4 principles stuff for years. Mostly when I hear from somebody who starts rattling off the principles, it doesn't take more than a minute or 2 that they're saying something that makes no sense at all, that shows they don't understand it at all. And if you look at their chapter on justice, there's almost nothing there that's useful to guide any decisions. So
Well,
my bottom line is, if you think that's useful, I think you're crazy.
Can I jump in, Mary?
Yes, sure. Go ahead, Lynette.
Okay,
and
I'll go see Stan, my psychiatrist friend, and maybe he can tell me that I'm not crazy because I happen to use them.
If I can jump in,
and Lynette, maybe you should identify your role,
okay.
Since I think it's relevant here, because I think what I'm hearing is we're really having a debate both about medical education as people enter the profession, but also then what are the railroad tracks or the guide rails for people once they have become medical professions, because we're certainly seeing lots of ethical issues all over the place. So Lynette, go ahead, please.
Okay, so
wait, who is Lynette? Lynette, you were going to tell me about your role in San Diego.
So I am a physician. I'm at UCSD. I'm the director of the clinical ethics program. So I have run our ethics consult service and committee for the last 15 years or so. So this has kind of really been my life for a long time. So what I'm confused about is the 16 duties that you outlined. It's kind of blending in the foundations of ethics case analysis, which is how I see Beecham and Childress, and transformed into a more practical framework. We use the Johnson 4-box method of ethics case analysis that's founded on their principles. And then you're mixing all that with our professional ethics, our ethics duty to follow the precepts of being, trustworthy and truthful, et cetera. But those don't apply to case analysis. So I think it's kind of mixing the two, which I find kind of confusing.
So the 4 boxes directs you to the kinds of information you need to collect. I think it's very useful for any clinical case decision. You need to collect the information that's relevant, and if you get stymied, then you have to see what other information might be useful and try to find that out, find those answers. Okay, but I think what you're dealing with is you've become very comfortable talking about 4 principles. Everybody can rattle them off, and then you do some hard deliberation. And yes, that's case deliberation. And my book is full of showing you how these different duties apply in different cases. So I'm all for using cases to explain, to help people understand what their duties are. But when you get down to the cases, Lynette, you can tell me, when you're talking about a case, a difficult case that you have, how useful are you using the 4 principles?
Yeah, I find them very useful. That's really how we structure.
So give me an example.
So we have a 86-year-old woman with advanced dementia who's bedbound nonverbal, is not eating, and the family continues to insist on placement of a permanent feeding tube, which we don't believe is ultimately recommended or going to benefit her in any meaningful way, because we're not supporting what we consider to be to us acceptable quality of life. So how do we sort that out? Right, we have to kind of break out the medical information, what treatment's being proposed, where feeding tube is being proposed and considered, what's her prognosis, how long is she expected to survive with the feeding tube or without the feeding tube, and what are the complications. Then we look at what the anticipated quality of life for her will be like and whether that's acceptable to people, including the treating team, what we think the patient would find acceptable and what the family finds acceptable. And then we try to ascertain what the patient's preferences are via the family or any advanced directives that she might have completed, because we would want to honor her preferences as much as we can ascertain them. And then the contextual features, who's going to take care of her, how is her care going to be covered, is there any religious or cultural values that inform the family's or the patient's decision making. Really try to synthesize all that information to arrive at the most ethically supportable courses of action in that situation.
So Lynette,
that's just
what I didn't hear from you was the word beneficence, non-maleficence, justice, and respect for autonomy.
Yeah, and those are all embedded.
You weren't, well,
I can frame it in those 4 values just as easily, I think.
Well, I don't know. Is that right? Because I think now we're talking about 2 different schemas. One is the 4 principles, and the other is the 4 boxes. And the number is the same. But the first of the boxes is just gathering the sort of medical information. So that doesn't have anything to do with an ethical principle. The second one is, what does the patient want? So that is respect for sort of autonomy. The third box is sort of the quality of life box. And I guess there's something about risk and benefit and beneficence there, but not so directly. And the third box is the contextual one, legal features, their insurance.
There's a component of justice in there, right? Fair use of resources have to be factored in.
I would agree, but I also would have to say, having taught these principles for years and years and years, we almost never talk about justice in these sorts of cases, or really, we don't have anything like, I think, the depth of analysis of issues of justice and fairness that.
Well, I think we do if we're concerned about excessive use of a limited resource and
Yeah,
trying
I
to
guess that's true.
assess what,
Certainly in the case analysis, we do look at that
Yeah.
sometimes.
Yeah.
I mean, I've been on those calls, right?
right.
But anyway, so Rosamond, I want to give you some space to respond.
So New York is very different from California, is what I just learned. So if we have the same patient and the family tells us, patient without an advance directive, the family tells us that mama would have wanted to live even if she were never going to communicate again, and these are her beliefs of a lifetime, and these are our beliefs, we would maintain her life without any, we would act to keep her alive regardless.
Mm-hmm. Right.
We arranged, we had a patient who was outside of the hospital living in her daughter's home with Creutzfeldt-Jakob disease.
Oh, yeah.
I'll say it.
Mm-hmm.
She had had the disease for 3 years, and they would have doctors come to the house and give her checkups, and they discovered a mass growing that was pressing on her liver. No reason to think it was cancerous. It was just this mass that could create problems. And should we do surgery? Never going to be conscious again in this terrible condition. The family said, this is mama's religion, and this is what it said, and this is what we think, and we want mama to live. We did a whole rigmarole to make the surgery feasible and happen and keep her alive.
Yeah.
Yeah.
You have legal prohibition from unilaterally limiting treatment. California is a state that allows unilateral limitations of treatment. So you're right, it depends on the setting of your practice.
So the legal issues are certainly relevant issues, the legal framework we operate in.
Right. That would be part of the contextual features of the case.
Yes.
But I mean, if we step back for a minute, and I invite others to join in, particularly those of you who have sort of relevant clinical and ethics experience. It seems to me that what approach different consult services take to consults varies some, and even if you look at the ASBH core competencies and so on, I mean, they allow for sort of different models of doing case sort of analysis. But Rosamond, I took it that your book is really more directed not just specifically at case analysis, although that's, and running an ethics consult service, that's certainly part of what those of us who are clinical ethicists do, but it's not part of what most physicians do. Many of the physicians on this call are very involved in and trained in and running ethics services. But for the vast majority of physicians, I think my understanding of your book and your project as outlined in the book was that it was really more directed more holistically at the medical profession, what a doctor was meant to be, what it is to be a professional sort of generally, but specifically what it is to be a physician, what kind of character, what kind of behaviors, what kinds of attitudes. And I see it, and I apologize for keep bringing this up. It's my own sort of orientation as a philosopher rather than a physician, but looking at medical education, not just training doctors, but keeping doctors sort of trained and competent and credentialed, is that this framework was really meant to help us understand what being a physician is, and deriving from that what the ethical duties of being a physician are. And that the argument is that if you just look at common morality, it doesn't really give you something that's expansive enough to cover everything we would want to cover, but that in key areas, it's actually directly contrary, and you gave good ones. I mean, you know, what you do to the body, what kinds of invasive questions you ask, and things like confidentiality, where the ordinary ethics just seems very at odds with what it is we're training doctors to do or expecting doctors to do. So I don't know if that helps at all.
I agree with everything you said, and I think the issue Lynette and Arnie are raising is they're comfortable with 4 principles, and I've just spoken heresy, which said, and I'm saying that stuff really isn't useful. The work is going on somewhere else, and the places where the difference in perspective really matters will be in these places where common morality says it's okay to do A, and I think the professional ethics says no way. So there will be places where you're going to run into big issues by cleaving to common morality. This whole issue of personal morality versus professional responsibility, where people will think, do I have to accommodate the medical professional? Another one would be the kind of situation where the patient is a racist and says, I don't want anybody of that color touching me, or a sexist, I don't want anybody from that gender touching me, and they're ready to die rather than have that happen. So do we have to act for the patient's good, or is it about not getting offended ourselves? I think you'll get radically different views. Now, I do the work, I'm the teacher and I'm the clinical ethicist. So I've been co-chair of our ethics committee. And before that, I was secretary doing the same work as co-chair of the ethics committee. So I do the clinical ethics work, but I think of my job as the medical educator is to put an ethics committee in every doctor's head, so they can be able to think through the ethical issues that they encounter every single day, all the time. And those are skills that every doctor needs. And there's a whole chapter in the book about how to think through a moral dilemma. Now, is it radically different from something you get from the 4 boxes? I think to me, I think it's better, because I don't think the 4 boxes give you a way of resolving anything. They give you the information to collect, but it isn't a way of resolving a dilemma. While seeking trust is a way of resolving a dilemma. It gives you a hierarchical principle that allows you to resolve dilemmas. Beecham and Childress give you no guidance for resolving dilemmas. It'll all be cases that they illustrate by specification. I've in ethic consults, several every week, I've never heard the use of those principles as being clinching or useful in the resolution. I know it makes you uncomfortable because you've been doing something different for years. I was doing what you're doing for years until 9/11. 9/11 started me noticing the places where you got real conflicts between common morality and professional thinking, and
yeah, I don't have any doubt that you've made a very good point in distinguishing how medical professional morality is different from common morality. But the Beecham-Childress paradigm is a tool, and tools require people to implement them. And you've given us some ideas about principles about how those tools might be used, and some of the guidelines. Don't you plug it in before you expect it to work, okay? And teach it. Well, and it would be wonderful if everyone went around with an ethics principle in their head, because then, but unfortunately, it would put people out of business, and maybe that's what's going to happen. But I think that I look at the 4 principles and the 4 boxes as tools which lead to deliberation. and deliberation takes thought and it takes argument. I would never, I could never even have trusted myself in a philosophy class in college. But in doing this for the last 35 years in ethics and applying, using this paradigm, I've learned how to make better arguments. And so it goes to a larger principle, and you as an educator can understand this. How do we get people to think or do what's called deep literary thinking? How do we get that to work? So my concern as a medical educator and ethicist is to ask that people think through things using certain principles, such as your 16 principles, if you will, or the 4 boxes or whatever. And that's what's lacking, in my view. And you might agree with me on that. Maybe not.
I don't think it's lacking. I think so 16 is a lot to remember. And I'm not asking people to remember 16. I'm asking people to remember 2. Number 1 and number 2. And that's what you have to remember. And in thinking through the cases, I think focus on, as a trustworthy medical professional, what is the right thing for me to do here and now?
Well, and in wrapping things up, because we're almost out of time and I don't want to hold people late, but I would say I recommend to all of you the book, which gives a much fuller sort of account of the project and how these, whether we want to call them ethical duties or principles, apply to various situations. So with that, I would really like to thank
Mary, can I just interrupt?
Oh, yes, Rosamond, sure. I was going to give you the last word. I just wanted to thank you. Go ahead.
One piece that you mentioned that I think is critically important, which is the character piece. That unless you recognize that this is part of what the agenda of medical education should be, developing what I call a doctorly character, you're missing a lot in terms of the education. And getting everybody to sit around and recognize, for example, that truth-telling is essential to being a good doctor, and seeing why and how you can't be trusted and trustworthy without that commitment. And it must be a sincere, heartfelt, enduring commitment, how that is an important part of being a doctor, and therefore it should be an important part of what we're trying to inculcate in medical education. That's the piece. The character piece, I think, is distinct, and it's not a big deal. You might find a couple of words in Beecham and Childress, but it is not a major theme.
Well, and I would agree certainly that when we talk about medical education, we're usually talking about content, scientific content, principles, skills, and so on. And I think we could actually have another whole discussion on the emphasis on character in your professional ethic, and how it is certainly something that in the book gets highlighted far more than what we sort of focused on today. But I would agree with you that that is a very different kind of emphasis maybe than what many of us are familiar with. So any other final thoughts, Rosamond?
I think I thank you for giving me so generously your time and giving me a hearing. And I understand this is going to make you uncomfortable if you've been doing this with commitment for 35 years this way. But it may be time for a change.
Oh, okay.
I don't have any problem being challenged with new ideas. Otherwise, I'd be retired by now.
Right. Didn't you retire once?
But you are
Arnie?
retired.
You came back, yes. No, exactly. I do want to thank you because this is a very deep and unusual. We talk about uncommon morality, but it's an uncommon approach to medical ethics. And I think it does cause a lot of us to think hard about, for example, how often do we actually, in discussions with patients or peers, when these ethical issues come up, or even in the more philosophical or theoretical settings, what are the approaches we're actually sort of using? So thank you again. I really was delighted to see you at ASBH and to meet you here, and perhaps when our current circumstances change, I look forward to meeting you in actual person. And Rosamond, thank you so much for joining us and for your efforts.